Hello, everyone, again. Dr. Tony here for you. Welcome back to Psych 316 Counseling Psychology, week two here at wonderful InterCoast College. This presentation, again, a very brief one. Let me share the screen with you so that we can get things moving and talking about what we need to discuss this week. So today we're going to start talking about your theoretical basis for treating patients. We talked a little bit about this in last week's presentation, but this week what we're going to do is we're going to embellish it a little bit. We're going to have three different topics. One of them is what theory draws you to you. The next thing is how theory fits into the counseling session that you will have, and it doesn't matter if it's group or individual. And we'll close up with your belief system, and I'm going to just talk about 6 theoretical bases. The main one that you're looking at for this course is going to be client-centered, but I want you to expand your horizons a little bit. Client-centered is a good one. It goes under different types of titles. It is Rogerian therapy, client-centered, person-centered, all of that. And we'll see where it goes from there. So let's start talking about client-centered therapy. What is it? Well, client-centered or person-centered therapy, you're talking to another individual. This was started by Carl Rogers back in the 60s. So it's a non-directive approach to talk therapy. In other words, what does that mean? It means that you're not going to tell a person, do this, do that, do something else. People generally do not like to be told what to do. I know I don't. If you ask me, or if you dialogue with me, what do you think about this? What do you think about that? I'm a lot more amenable than you got to do this, you got to do that. That's where you get a little pushback, and that's where you catch an attitude. If it happens to me, it's going to happen to your patients. You tell a patient what to do just to shut you up. They'll say, okay, I'll do it. And when they come back to session next week, guess what? You ask them, did you do it? They're going to say, oh, geez, this came up and that came up. So Rogers came up with this system where he doesn't tell the person what to do. What he does is he gets the person to talk to him, and by talking to him, the person then turns around and sits there and comes up with, well, what do you think about this? That's where you want to go. It requires the client to actively take their reins on their own issues. You don't want to take the pain away from the client. You want them to be in their pain. I know that sounds strange, but you want to keep them in their pain, and you want to teach them to walk through their pain by walking into their pain, accepting it, and then moving through it and out of it. So you, the therapist, act mainly as a guide, a coach, if you will, a sense of support for the client. It allows you to put the client in charge of steering their own ship and not you steering the ship. So when you start to go through this class and you start to look at your literature and some of the other materials that are presented here, look at this. At one point in the clinical work, this was a great thing back in the 60s, 70s, and 80s, and all of a sudden it started to fade away, and it's like, no, this isn't really good. Well, guess what? It's circling back. I happen to find this one of the best theoretical basis. The other thing that I want you to start looking at is something called motivational interviewing. There's a wonderful book by Miller. It's called Motivational Interviewing. Look it up online. Go take a look at it on YouTube. For presentation on it. It focuses on exploring and resolving a person's ambivalence within themselves. A lot of times, addicts and alcoholics, and even those with a mental deficiency, mental illness, if you will, mental challenge, as we call it now, they're ambivalent. I don't know what to do. I don't know where to go. They start to panic, and this is what causes people to use. Remember what I said in the last videotape, right? The use of a drug is only a medication symptom, right? It medicates the real problem. That's a symptom. So we're taking a look at somebody that's an addict, and we want to know why they're using. Well, they're ambivalent about something that's going on in their life. I don't know how to do this. I've lost this. I've lost that. I need to feel differently. A lot of addicts that I've treated, when I ask them, what got you to use? I needed to feel differently, or I can't feel, or I don't like the way I feel, I needed to change, or I'm depressed all the time, I needed to pick up. Everybody else is doing it, so I decided to do it. Well, if everybody else is doing it and you see that they're getting messed up, what's the reason for you doing it? Right? So the idea is to resolve this ambivalence within them and to motivate them, to get them to want to change. Now, how do you do this? Well, again, we don't want to go to, as I said in the last video, the Spanish Inquisition, asking 10,000 different questions. But what you do want to do is you want to ask them enough questions for them to understand exactly what's happening. So tell me what you're using. Okay, so let's say they're using methamphetamines. Well, could you tell me now, once they tell you something like that, that should zero you in on what's going on inside. When I see people using methamphetamines or any type of amphetamine at that point, including Ritalin or anything like that they may be using, the first thing that comes to my mind is focus. Focus. People that have attention deficit hyperactivity disorder, ADHD, the medication of choice at this point in time is a stimulant, Ritalin, Xyler, that type of stimulant. What that does is it takes this and pulls it to this. So when you're ADHD, you're all over the place. You can't focus, you can't think. You'll start something, you'll pick it up, you'll drop it and move to something else. You get bored quickly. These types of things happen. You can't understand things because your mind is racing all the time. So believe it or not, they give you a stimulant. And what the stimulant does with somebody with ADHD is it slows them down. It has the opposite effect of what a stimulant normally does. Somebody that doesn't have health insurance will go out on the street and find a drug dealer, and the drug dealer will sit there and say, here, try this stuff. So they give them a methamphetamine, and all of a sudden they find out, hey, this is starting to work. It's getting me high as a kite, but at least I can focus now. Well, if you know that's the reason, if you can understand that, then you can talk to the person about, tell me a little bit about what's going on with you when you're not taking the medications, when you're not taking the drugs. What do you want to do with this? How do you want to stop? Let's talk about ways that you can stop. Let's talk about all these different avenues that you have. You're not ready to stop using yet? Could you tell me a little bit of what that's about? What are the positives and negatives about you using? This is all part of motivational interviewing. So take a look at Miller and his works on motivational interviewing and tie that into how that would fit into, let's say, client-centered theory. So if your basis is going to be Rogers, if you're going to start with client-centered theory and you're going to start with focusing on the person, then take the motivational part of it and pull that into client-centered theory. Make it a part of client-centered theory. From there, you start to talk to the person. We talked about this in the last session also, cognitive behavioral theory, Aaron Beck. So cognitive behavioral theory, this is kind of like the current trend right now in addictions treatment. You have different types of ways that you think about yourself and think about what you do. These are called irrational thought processes. These are called different types of thought processes and different types of ways of pulling things together. So it's a treatment approach that helps you recognize negative, unhelpful thoughts to you and unhelpful behavior patterns based on your thoughts. I call this a functional dysfunction. That's my term for it. You're functioning, you're working, it's been working for you forever, but somehow it always trips you up, it always messes you up. So you're functioning in a dysfunctional way. That dysfunctional functioning gets you to use. And as you use, it just turns into a cycle that goes down to the point where you kindly lose everything. So CBT, cognitive behavioral therapy, aims to help you identify these ambivalent thoughts, these unhelpful thoughts, these negative thoughts, and to explore ways emotionally and cognitively to work through them. So this way you can change your actions, you can change your behaviors. If you change your thought, you change your behavior. How do you get to this? You get to it through motivating your client. You get them to talk about it, these motivational interviewing techniques. So once you start to get them to identify these thoughts, you don't identify, the patient does. Do that through motivational interviewing. You then talk to the patient as a client-centered theorist, and you let them direct. So how can you change these negative thoughts? You just told me this is how you get there. What are some of the things you think you can do to change them? Now, that doesn't mean you can't interject. Of course you can. But at the same time, you want the client to be able to do this. All right. The next that we're going to be looking at is what's known as DBT, dialectical behavioral therapy. This was started by Marshall Linehan. Now, DBT was originally used for borderline personality disorder. This is what's known as personality disorder. It is embedded in the individual. Again, the only way you're going to know about this is if you take a look at the DSM-5-TR. We talked about this in the last session also, Diagnostic and Statistical Manual of Mental Disorders, 5th edition text revision, DSM-5-TR. Look under personality disorders, look at borderline personality, and this will give you an idea. So DBT is a type of cognitive behavioral therapy. Here it is, for theoretical basis, right? Cognitive behavioral therapy tries to identify and change negative thinking patterns and pushes for positive behavioral change. It can be used to treat suicide and other destructive behaviors. Linehan did is she took cognitive behavioral therapy, believe it or not, Zen Buddhism, and blended them together. There's your dialectic, right? So it gives you the idea of being in the moment, right here, right now, how to stay in the moment, how to work through it in the moment. As you do that, you start to work through your process. So let's say you're working in the moment. You're doing DBT. You've got these negative thought processes. Here you are at cognitive behavioral therapy. So you approach it by looking at the negative or unhelpful thoughts. You then stay in the moment. It's called mindfulness exercises. And we take a look at in dialectical behavioral therapy 3 ways that you approach reality. You've got the wise mind that sits there and is constantly logical, right? I'm sorry, you've got the emotional mind, which is out of control. You've got the logical mind, which is totally logic. And then you've got the wise mind, which pulls the emotional and the logic together, right? And you do that by staying in the moment. And what the DBT tends to do is keeps you there in the moment. So all of a sudden, right at the moment, you've got these negative thoughts coming in. So you're taking a look at your negative thoughts right here, right now. You're taking a look at the way that you react within those. There's your CBT. So then you start to ask your patients exactly to explore this and what led you up to that. This is also a technique, motivational interviewing thing that Linehan uses to start to trace your thought processes. Okay. So as you start to trace your thought processes, you ask the patient, what led you here? What led you there? How you're responding to this? How you're responding to that? What's getting you to use? And then you start to use your client-centered theory techniques to sit there and in a non-directive way to get the client to explore what they want to do and how they want to heal. Now, as you're going through therapy, you're finding that your clients are looking kind of they're saying one thing, but their body language is something else. We talked about this briefly in the first session also, where the client's arms are folded, their face is all wrinkled up. How you doing? I'm fine. I feel just great. And you point these things out to them. You know, how come your arms are folded that way? How come your face looks that way? Why are you tapping your finger on the chair or on the table? So it's a form of psychotherapy that's centered on increasing a person's awareness, again, in the right here and now. Their freedoms, their self-direction, their destructive behaviors. It's a form of therapy that focuses on the present moment rather than past experiences. Because the past experiences are embedded in the individual, and they're reacting right now in an unconscious way to deal with those past experiences. So Gestalt therapy is based on the idea that people are influenced by their present environment. And the way they react to the present environment is what happened to them in the past. So the way to do this, as we go back to dialectical behavioral therapy, is to take a look at the right here and now, to stay in the present, to be mindful of where you are in the present, to take the logical mind and the emotional mind, pull them together into the wise mind and say, this is why I'm reacting right now. And then as we do that, we start to look at the negative behaviors that we have. And then you as a therapist are going to start to question the person and start to dialogue with the person as to the ambivalence that they're having, and then move them into their approach, the client's approach, into what's going to make them feel good. Individual counseling is sometimes called psychotherapy, talk therapy, or treatment. This is what you're going to be doing. This is the whole point of you getting your own theoretical basis. It's a process that works one-on-one with an individual. You're going to be trained to do this. This is what you're in school for. And it's safe. The environment you want to make safe. You want to make very comfortable for the person. You want to make it very caring. You want to make it very confidential. So we're going to talk a little bit about that in another talk when I talk about ethics. So in individual counseling, by this point, you're going to have your theoretical basis. You're going to be thinking about how are you going to blend these things together into your own way of dealing with it. I don't care what you call it. The idea is to come up with your own theoretical basis and to do it. In my dissertation, one of the things that I do, I'm a judo player. I'm a 10th degree black belt in judo. So what I did in my dissertation is I decided to use judo as a part of therapy. So I've taken all the 6 techniques and some other ones that I haven't shown you, and I took the judo techniques that we have, 179 of them, and I broke them apart in depression, anger, and anxiety. And as I did that, I wanted to see how responsive the patient was if I used my technique, blending it together, which I called system-centered judo therapy, pull that together, find out where they were, and then use judo to relax them or to get them to use their force, their techniques to get rid of some of their emotional stress. Worked out beautifully. That's my theory. Okay, what's yours? So as we close this out, let me stop sharing the screen for a moment. There we go. As we close this out, I want you to continue to think about your theory, your basis, and how this is going to work. So take a look at these 6 theories that I gave you, okay? And as you take a look at them, move through them, look back at the first week, see how these 2 tie together, and I'll catch you next week. Take care. See you soon.